It's really delightful to be back here and to have the opportunity, hopefully, to entice some of you to engage with the ICDDR B. I think you'll see that there are tremendous opportunities for folks from diverse disciplines at all levels of training. The ICDDR B, which even I have trouble pronouncing, is actually quite a venerable institution. It's probably the oldest freestanding health research organization in the developing world, having started in 1960. So it's over 50 years old, and it's gone through several transitions over the world. It's a international research organization devoted to research problems on the health of populations living in poverty in developing countries. It's located in Bangladesh, which, as you can see, is a country in South Asia, surrounded by India, except for a narrow border with Myanmar, across which diseases like drug-resistant malaria, unfortunately, travel. Bangladesh has several notable features. It's the most densely populated country in the world. It has a population of 160 million people who are squeezed into an area the size of Wisconsin. And of course, much of this area floods seasonally and is not permanently inhabitable. It's a low-lying, deltaic country laced by rivers and sitting on the Bay of Bengal. And of course, off the Bay of Bengal, periodically there are typhoons or hurricanes that hit Bangladesh. There are periodic floodings, all of which led former Secretary of State Henry Kissinger to call Bangladesh the world's basket case. Well, I think you'll see that it's a lot has happened there to argue against that terminology. I mentioned it was established in 1960 as the Pakistan CETO Cholera Research Laboratory. And this is kind of an interesting artifact of U.S. history. CETO stood for the Southeast Asian Treaty Organization, which was the U.S. government's attempt to organize Asian countries to fight against the spread of communism in Asia, to blockade the so-called domino effect. And Pakistan, it was then Pakistan in those days, was a member of CETO, and this organization was created as a kind of what we would now call soft diplomacy. It had nothing to do, obviously, with the military, but it addressed cholera, which was one of the major problems confronting this population, offered care, did research, and so forth. In any event, and at that point, it was a U.S., essentially NIH outpost. In 1978, it became the International Center for Diarrheal Disease Research, Bangladesh, which is where the initials come from, as a freestanding international organization with a broadened mission to include population studies, maternal and child health and nutrition research, in addition to diarrheal disease research. The center has made several really seminal contributions to global health over the years. As a matter of fact, it's hard to think of any single organization that has contributed more to global health than this place. It was a place where oral rehydration solution ORS was not only developed but tested for effectiveness and shown to be usable in the home, with mothers making it to treat their kids with diarrhea. The medical journal Lancet has called ORS the single most important medical discovery of the 20th century. It has saved an estimated 50 million lives over the years. Subsequently, the center demonstrated that co-administration of zinc with ORS adds to the benefit of ORS. In fact, has a remarkable effect in reducing overall childhood mortality, and is now a standard of care globally. The center has conducted several seminal studies on vaccines. Believe it or not, in the 1980s, actually, when I was a scientist working in Bangladesh, measles vaccine was virtually not used globally, in part because of a theory that hypothesized that measles vaccination didn't have much of an effect on child survival. The notion being that children who died of measles or who got measles, if measles were prevented, would go on to die of a comorbid illness such as severe malnutrition. It was actually in Bangladesh that the very opposite was shown, that measles vaccination has a long-term effect on overall childhood mortality that is actually greater than we predicted on the basis of prevention of acute measles deaths. And that study was critical in moving measles vaccine into the EPI. This was also the place where it was shown that administration of tetanus vaccine to women of childbearing age protects against tetanus not only in themselves. Obviously, this is a major problem in maternal mortality for women delivering at home, but also neonatal tetanus, which used to be the major cause of neonatal mortality in the developing world. And this then, of course, became a cornerstone of global efforts to prevent neonatal tetanus. It was also the place where it was first demonstrated that you could vaccinate against cholera, severe diarrheal disease, by mouth. The old vaccine was injectable, and based on these data, the entire field transitioned toward oral vaccines. It was also the place where it was shown that vaccinating women, pregnant women against influenza, protects not only themselves, but also protects their newborns against influenza during infancy. And this has become a global policy recommendation. And it was a place that showed that in poor countries of Asia, that modern oral rotavirus vaccines against rotavirus diarrhea could have a meaningful impact, which led Gavi, the Global Alliance for Vaccines, to recommend the use of these vaccines globally. As well, it's a place where a seminal work in population studies was undertaken. I mentioned that population has been a huge public health problem, too much population, for Bangladesh for many decades. And when the center was formed, it had a mandate to address the population problem. Well, first of all, it set up the very first field site that was able to track the demographic events of a large population anywhere in the developing world, the so-called demographic surveillance system, monitoring all births, deaths, and migrations in a place called Matlab, a very famous field site of the center, which still exists. A population of over 200,000 people visited at home weekly or biweekly to track all these events. And so now the center has a dynamic computerized database covering 4 generations of families in Matlab, and is an extraordinarily rich source of studies researching population. But as well, Matlab was a place where innovations could be tested in the realm of family planning. Clearly, delivery of contraceptives was a major challenge in the conservative Islamic rural Bangladesh areas. And after many trials and errors, some very, very bright researchers at the center, Lincoln Chen and Henry Moseley, came up with the idea that the best way to deliver contraception was not through the medical care system, but through neighborhood women, community health workers, who also were trained to give simple primary health care interventions, such as oral rehydration solution. And it was found that use of these so-called community health workers was extraordinarily effective in raising levels of contraception in Bangladesh, as you can see here, and was largely responsible, when it was taken to scale countrywide, for what is just an eye-popping success of Bangladesh in fertility decline. You can see from this graph, this is births per woman. In 1975, the average woman had over 6 kids. This has now declined over time with contraception and the use of this community health worker strategy. Well, 2.3 in 2011, it's now 2.1. It's essentially at replacement now, a dramatic success in the realm of family planning that many countries have tried to emulate. As well, taking to scale countrywide the childhood interventions that I mentioned, ORS and vaccines and so forth. The Bangladesh government was able to accomplish something that very few other governments have been able to accomplish, namely a reduction of under 5 mortality over the years, meeting Millennium Development Goal 4. As a matter of fact, Bangladesh is one of 6 countries in the world that have succeeded in achieving the 2 major Millennium Development Health Goals: 4, reduction of childhood mortality, and 5, reduction of maternal mortality. Though, as you can see, reduction of neonatal mortality, that is death during the first month of life, has been a tougher nut to crack and remains a challenge. I would recommend to you an issue of The Lancet last year that had several papers devoted to what was called the Bangladesh paradox. Namely, how could this poor, besodden country, the most overpopulated country in the world, one of the most impoverished countries in the world, a country that had really a very lousy government healthcare system, how did it succeed in achieving MDG 4 and MDG 5? And there are many reasons. It's a very interesting read, but one of the reasons, it was documented in an editorial written by the editor of The Lancet, Richard Horton, basically crediting the ICDDR B with serving as a test bed for these interventions and with the openness of the government to take these interventions to scale countrywide very rapidly to achieve these benefits. The center was also acknowledged last year by Secretary General Ban Ki-moon of the United Nations in a special meeting in New York devoted to the role of the ICDDR B in its innovation in meeting the challenges of the MDGs. And I was actually quite surprised that Mr. Ban was willing to stay for all 2 hours of the workshop. For all this, the center was awarded the very first Gates Award for global health. And I like to tell the story that about a year ago I was visiting Peter Piot, the dean of the London School of Hygiene and Tropical Medicine. And I was waiting in the lobby to be ushered into his office and just kind of looking at the trophy cases of the London School. And I saw they proudly showed the fact that they won the 9th Gates Award, but I decided not to rub it in with Peter since I was there to ask for a favor. So one could ask, well, this is great. I mean, it's a very, it's an extraordinarily rich history, but you know what the world says is, what have you done for me lately? What is the next ORS? Well, ORS obviously is a very tough act to follow, 50 million lives and so forth. But there is a very interesting pipeline of new interventions that are being developed and tested by the center in Bangladesh. We're testing a variety of prenatal nutritional supplementation strategies to improve not only maternal health, but birth outcomes and infant mortality. We are testing an innovative use of these female community health workers to visit homes of newborns born in the home shortly after birth and to screen these kids for signs of sepsis, overwhelming bacterial infection, and to refer them when needed, even to give them an initial shot of parenteral antibiotic if referral is going to be delayed, with actually a fairly remarkable effect on neonatal mortality. We're very much involved in strategies to deal with severe acute malnutrition, which when I was in medical school went by the names kwashiorkor and marasmus. Now they're grouped as severe acute malnutrition, which are estimated, this syndrome is estimated to kill about 1 million kids per year globally. Now our hospital is full of these kids. We have a whole ward full of kids that look like this. And we've devised clinical protocols for treatment of these kids that reduces their expected mortality from about 35% to about 5% when they come in with other problems. They always do come in with other problems. They come in with severe diarrhea, they come in with pneumonia, they come in with tuberculosis, or a combination of the above. But once you've gotten them over the hump with respect to these presenting syndromes, you then have to consider how are you going to nutritionally rehabilitate them before sending them home, a process that takes several weeks. And a key element of nutritional rehabilitation is energy-dense therapeutic foods with a variety of micronutrients that these kids can ingest and that their very small stomachs, you know, can handle while getting in the calories that you need to get in. Now, internationally, there is a standard ready-to-use therapeutic food called Plumpy Nut, a peanut-based ready-to-use therapeutic food. But it's produced by an international company in France. It's very expensive. It's too expensive actually to be widely used. And so our scientists have developed an alternative based on local ingredients, lentils, etc., and which we think will go for about 1/3 of the price of Plumpy Nut. And we're now testing this ready-to-use therapeutic food in non-inferiority clinical trials against Plumpy Nut for clinical outcomes. Another area where we're involved with new interventions is the area of maternal mortality. I mentioned that maternal mortality has come down to a level in Bangladesh that meets the Millennium Development Goal, but there's still a lot of it, and the major cause is hemorrhage, bleeding during delivery. Now this poses a particular problem because most women in Bangladesh deliver at home. 70% of all deliveries do not occur in a facility, they occur at home. And so the question is, how do you address this problem of maternal hemorrhage? And what our scientists have done is to expand the traditional clean birthing kit that is used commonly in developing countries to include 2 items. One is the prostaglandin misoprostol, that can be given by mouth, a tablet immediately after birth to sort of clamp down the uterus and hopefully prevent hemorrhage. But of course, that doesn't always work. And so they've developed a means to monitor hemorrhage. Now, why is that important? Probably one of the first things that you learn in medical school is how difficult it is to gauge the amount that a patient has bled visually. Very difficult. And if it's difficult for doctors and nurses, you can imagine how difficult it is for people at home after a home delivery. And so what one of our scientists has done is to develop a new birthing mat that the woman sits on during delivery. And it is designed in a way that it becomes saturated with the passage of 500 milliliters of blood. That's 1 unit of blood, which is an amount that most obstetricians believe is a clear warning sign of the need for referral to a place where the woman can be transfused. We've tested the feasibility of this kit in over 100,000 deliveries in northern Bangladesh, and are now about to proceed with effectiveness trials to actually look at the impact. We're also involved with implementation research. Implementation science is kind of the flavor of the month in public health these days. And we're doing things in several areas, one of which is so-called menstrual regulation. Now, menstrual regulation actually is a euphemism for early pregnancy termination that is commonly used and is perfectly legal in Bangladesh. Several 100,000 women per year undergo vacuum aspiration to do this. But obviously there's a desire for a non-invasive and safe and effective means to accomplish this. And our folks have done a large study to demonstrate the feasibility and efficacy of using the combined oral drug mifepristone, misoprostol, and have shown good results so that the drug authority in Bangladesh has now approved this for that purpose. As well, in the area of oral cholera vaccines, which I mentioned, the center was sort of the seminal place to start this story in the 1980s. There is now an oral cholera vaccine that is internationally licensed, that is stockpiled by WHO, but there's the need for implementation research, how to give this, and we are just completing. In fact, we've broken the code on a large implementation cluster randomized effectiveness trial of oral cholera vaccine in urban Bangladesh, which enrolled something like 250,000 people. And the paper reporting on those results will appear in the Lancet in a couple of weeks. As well, we're moving into new scientific areas beyond the area of intervention research. When I was a young scientist at the center in the 1980s, the laboratories could best be described as Louis Pasteur issue, with the candle burners and so forth. Those days are long gone, and actually the center now has laboratories capable of doing really cutting-edge modern molecular science. An example in molecular microbiology by our scientist Shah Farooq, published as a letter in Nature, examined the roles of phages in toxigenic conversion of Vibrio cholerae. And more recently, also in an article in Nature, our scientists collaborated with Jeff Gordon at WashU, looking at the interesting issue of the relationship between the gut microbiome and malnutrition, with some very intriguing data suggesting that the microbiome may play an important role. As well, we've entered sort of the human genetic era, done a variety of studies of looking at human genetic susceptibility to diseases that affect Bangladesh. This is an example of a study that reported several SNPs correlating with the risk of cholera in Bangladesh. We're doing quite a bit of research on emerging pathogens. We have a group at the center from US CDC seconded to work with us and have been for the last 10 to 15 years on a whole variety of problems. Bangladesh basically has everything. Avian influenza, in which we have both veterinarians and human epidemiologists dealing with the problem of bird flu in a one health kind of fashion. We have programs on HIV, drug-resistant tuberculosis. We have an area of the country that is endemic for visceral leishmaniasis, or kala azar, and are doing important work in drug trials for this condition. We are the only country in the world that has endemic Nipah virus, encephalitis. You may, for those of you who don't recognize that, if you saw the Hollywood film Contagion with Matt Damon and Kate Winslet, that was actually based on a hypothetical Nipah virus epidemic dreamt up by Professor Ian Lipkin at Columbia University, and on anthrax in both cattle and human cutaneous. We have a lot of anthrax. But at the same time, another epidemic is emerging in Bangladesh. It still has a huge burden of the good old-fashioned diseases, the choleras, the kala azars, and so forth. But if you look at the data from MATLAB, this is the study area that I mentioned, where we've been conducting surveillance for 50 years and have been doing verbal autopsies on all deaths. You see a rather striking trend, and that is now the overwhelming predominance of non-communicable diseases, primarily cardiovascular disease, as causes of death. And with the help of Professor Zhang and others, we have started a non-communicable disease research program leveraging our ability to do these large population-based studies that very few places in the developing world can do. We're involved in health systems research, universal access to healthcare, as you know, is a major agenda item on the global agenda and probably will be in the post-MDG priorities. This represents a demonstration project of an innovative community health insurance scheme in a rural community in southern Bangladesh, basically getting community members to pool their money to use for treatment of health care. Although there is a government health care system, probably 70% of all health care costs in Bangladesh are out of pocket. As well, we've begun to do research to deal with this. This is what I see out of my office window every day. This is a sprawling urban slum in Dhaka. And this is not really, this is not a good place to live. As I mentioned to you, the population density of Bangladesh is the highest in the world. The urban slums have population densities 8 times the national average. The health indices are atrocious, and it's increasing as a problem. When I worked in Bangladesh in the 80s, something like 10% of Bangladesh was urban. It's now 25%, and by 2050, it will be 50%. And there's an enormous need for research on problems of the urban slums. Finally, we've started programs on climate change. Bangladesh is the most climate change affected country in the world by several estimates. And, you can kind of see why. The country sits on the Bay of Bengal. I mentioned these huge storms come off the Bay of Bengal to ravage populations, but as well, the sea level is rising. And as you can see from the legend in this slide, most of Bangladesh is not far above sea level. So when the sea rises, it moves inland with a variety of consequences that in some ways, from a research point of view, are fascinating. Obviously, from a human point of view, are disastrous. One is that there's progressive salinization of the soil in southern Bangladesh, so that farmers find they can no longer competitively grow crops. And so what do? They move to the cities, and they occupy those urban slums. That's one of the reasons that the urban slums are increasing. As well, there are clear-cut health consequences. We think, for example, that the movement of saltwater inland is increasing the problem of cholera, which is a bug that likes to live in saline environments. But it's also increasing the problem of hypertension and preeclampsia of pregnancy, particularly in the South, where drinking water is becoming incredibly salty. So it is really one of the laboratories, if you will, of the world for seeing what happens with climate change and seeing what you can do about it. Well, that's a lot of stuff, and how do we do it? Well, it's actually a rather big organization. We are 5,000 people with over 200 scientists. We operate 3 hospitals. This is the largest. This hospital is right beneath my office in Dhaka. Collectively, our hospitals see about 220,000 patients per year, primarily with diarrhea and malnutrition. We treat all patients free of charge. And as you can see this is what the hospital looks like during epidemic season. The people are very poor. On a bad day during the cholera season, and cholera does occur seasonally, we will treat 1,000 patients a day. So it's an immense clinical service, but with obviously tremendous research opportunities. Here's another hospital that we operate in Matlab, where I showed you earlier as the demographic surveillance is going on. We are, without question, the world's experts in the control and treatment of cholera. Our hospitals see about 10,000 cholera patients every year. Nobody sees cholera like that. And as a result, we're regularly asked by the World Health Organization to go to places that are afflicted by cholera epidemics. We are asked to go to Haiti, where our teams played a very important role in correcting the horrific errors that were being made in maltreatment of cholera by the various NGOs on the scene. We have recently sent teams to Cameroon, Sierra Leone. Our teams were recently in northern Iraq to take care of Syrian refugees fleeing the problems in Syria. We've had recent activities in Kenya, the Philippines, and elsewhere. And this actually, in addition to being a very important humanitarian issue, one that actually was featured by the Clinton Global Initiative, provides a research platform for strategies to deal with cholera epidemics. I mentioned to you that we have state-of-the-art laboratories, and this really distinguishes us from most research institutions in developing countries. There are research institutions that have access to clinical or field populations, but very few that actually can bring modern molecular science to the problems of populations directly. We have tremendous surveillance capabilities. In the shaded area are 5 field sites throughout the country. At the present time, we have over 1 million people under surveillance in these sites that it can be used for anything. We happen to use them primarily for infectious diseases and neonatal health, but they could be used for anything. As well, we have a surveillance system of 12 hospitals in the rectangles for sentinel surveillance of patients to detect emerging diseases. And we have programs for detection of emerging respiratory infections and encephalitis right now. We do a lot of training, and we've had UCLA students out. There was one actually out last summer. So over the years, the UCLA students have come for training. We have a lot of international trainees, 18 countries last year, in a variety of areas. And we have a school of public health, believe it or not. But we're not your competitors. It's a very interesting school of public health that really was designed to give students the training necessary to work as professionals in developing countries. And it's very interesting for our students because 2 organizations sponsor this school. One is the ICDDR B, which offers research opportunities for students. But the other one is an organization called BRAC, which you may not have heard of, but is a very, very famous non-governmental organization. It's actually the largest non-governmental organization in the world, with over $1 billion a year budget devoted to poverty alleviation. So the students who are interested in research can work at the ICDDR B. Those that are interested more in development can work with BRAC. We do a lot of collaboration. This is just a long list, but just to illustrate that we have multiple collaborations with North American, European, African, Asian, and Australian organizations. And international collaboration is very important to us. You know, science these days is really an international process. You can't do great science in solo anymore. And so we are very keen to establish more relationships. One of the reasons I'm here, in addition to seeing many old friends, is hopefully to elicit interest on the part of the UCLA community in really taking advantage of the incredible opportunities presented by the center. Our core donors are shown here, the governments of Canada, Australia, the UK, Sweden, and Bangladesh. And we operate on about a $65 million a year budget, which I guess is about the same size as this School of Public Health, I think. Though we don't, as I said, we're not competitors. About 15% are core donations, 85% are grants. So our people are very good at getting grant support. Where are we going in the future? Well, we're very keen to develop this pipeline of interventions that I showed you into public health reality through evaluations and other studies to provide an evidence base for their introduction, if their introduction is indeed warranted. We are very much involved and progressively involved with implementation science, with studies that leverage our laboratories and our international collaborators for studying infectious diseases, malnutrition, prematurity, and NCDs. We really want to better leverage our extraordinary field sites for population-based studies that take advantage of our laboratory capabilities And progressively, we're extending our footprint outside of Bangladesh. In a few weeks, I'm going to Myanmar to set up several studies of mutual interest in Myanmar. As well, we're exploring studies together with the Hansen Institute in Addis Ababa, Ethiopia. So to summarize, we have a 50-plus year history of serving as a test bed for developing and evaluating interventions that have revolutionized global health. While initially focusing on diarrhea, malnutrition, family planning, and population studies, we've expanded to encompass many infectious diseases, nutrition, maternal and perinatal health, child health, reproductive health, chronic diseases, urbanization, climate change, and health systems. We're complemented by our training programs, including our School of Public Health, and this really broad agenda has been made possible by a large multidisciplinary staff with access to research subjects, state-of-the-art clinical facilities, laboratories, multiple field sites, and robust funding. As I mentioned, international collaborations have been central to our success, and we feel that to raise our science to the next level, we need to increase these. And so I'm more than happy to talk with any of you who would like to engage further with us, either in training or in science, because we are genuinely interested in reaching out. Thank you very much.
Time for some questions.
Just a quick question. You haven't mentioned HIV. Do you have special things going on, or is that?
Yeah, we have, HIV, for reasons that are completely unclear, Bangladesh has been largely spared of HIV, which is in and of itself is an interesting question. It has extraordinarily high rates of other sexually transmitted diseases, and it's really, it's just a very interesting research question that has not been pursued. Our HIV program is supported by the Global Fund, and it's really addressing the problems of marginalized groups, especially the transgender community, and the male, the men having sex with men community. We operate, in addition, the country's only really competent AIDS ward in our hospital. It's not very big. It only has about 10 beds, but it's the only place in Bangladesh where you can receive modern AIDS clinical therapy. I mean, there are other places where patients are treated, but not competently. Interestingly, most of our patients acquire AIDS working as workers in the Gulf states. And I suspect other exporters of these workers are experiencing the same thing.
I was wondering, do you play a partnering role with the Brahmi Foundation, Muhammad Yunus? And is there a reason you avoid USAID money?
Well, we don't avoid USAID. We don't avoid any money. We don't receive core money, unrestricted money that we can do whatever we want with from the U.S. But we receive a lot of, several $1 million a year from USAID. And we do interact with Professor Yunus. MATLAB has a very active microfinance activity. And actually, the demographer Jane Mencken, I don't know if you know her, she's a very famous demographer now at University of Colorado, has been working with the center for years and is now taking advantage of the incredibly rich data set of MATLAB to evaluate the health impacts of microfinance and other activities that have been phased in over time.
More questions?
Could you
explain more about that blood mat and how it actually works? I mean, how does it distinguish between other fluids that might come from the woman? And then is there like a trigger mechanism or some kind of beeping sound?
Yeah, no, I think it's much cruder than that, and it doesn't really distinguish from other fluids. It's kind of, it's kind of meant to be as simply as possible. As cost is everything in these things, but by and large, it certainly, in vitro, it becomes saturated by about a unit of blood, and obviously, if other fluids are taking part, well, that's not necessarily a good thing, but maybe it is. Maybe it sets a more conservative threshold for referral of the woman for transfusion.
Yes, thank you for your talk. How about tobacco control?
Needed. Smoking in the male population is very, very prevalent. COPD is very, very prevalent. We have no idea what the problem of, the magnitude of lung cancer is, but we can guess. And it's undoubtedly contributing to the cardiovascular problem as well. That would be a very interesting area for us to get involved with for the following reason. We really don't have the clinical capacity, to deal with cancer treatment trials or cardiovascular treatment trials, but we do have a tremendous capacity to deal with prevention, large-scale prevention activities for NCDs. And smoking would be an obvious, but we haven't gone there yet. It's a young program. It's only about 3 or 4 years old.
Yeah, not only smoking, chewing tobacco is a major issue there. Head and neck cancer, oral cancer, ranked #1 in the whole world because of chewing.
I was interested to learn about the cholera vaccine that you guys are giving in Bangladesh, but in the urban setting. Why did you guys choose the urban settings as opposed to the rural settings to pilot that?
In Bangladesh, cholera has become largely an urban disease. Reasons for that are not entirely clear, but it's well documented. Maybe related to increasing population densities. A lot of our cholera patients come from those slums where access to clean water is very minimal. Actually, it's not so atypical. In many places in the world, urban populations are suffering disproportionately from cholera. Now, the challenges of giving a cholera vaccine in an urban setting and a rural setting are different. And so, whatever success we had in this particular project may not generalize readily to a rural setting, which would probably have to be separately addressed.
Okay, thank you very much, John.
Thank you.